you so much for joining us today. I am Janina Ong, a program analyst at the Association of Maternal and Child Health Programs, also known as AMCHIP. Today we are talking about our Safer Childbirth Cities initiative in this presentation called Catalyzing Communities for Impact. I just want to talk to you guys a little bit about what the Safer Childbirth Cities initiative is. It is a Merck for Mothers initiative that serves communities across the United States. Merck for Mothers is a $500 million global initiative to help prevent end preventable maternal death. Learning that's from CDC data that maternal mortality is rising in the United States with a growing disparity among Black and Indigenous populations, Merck for Mothers has been exploring how to address this by bridging the gap between communities, hospitals, and healthcare systems. So the Safer Childbirth Cities initiative was launched in 2018, and it fosters local solutions to help cities become safer and more equitable places to give birth. You can learn more about this at www.saferchildbirthcities.org. Our missions and goals. The initiative aims to support community-based or community-rooted organizations in the United States that have a high burden of maternal mortality and morbidity to implement evidence-based interventions and innovative approaches to reverse the country's maternal health trends and directly tackle racial inequalities and inequities in maternal health outcomes. So I'm from AMCHIP, as I mentioned. Merck for Mothers really handled the request for proposals and the application process and provided support for a grant period of 3 years to each of their grantees. This year, cohort 1 began their final year of funding, and cohort 2 will enter that second year of funding. In each of our cohorts, there were 10 cities selected. So let me show you our cities, and then I'll tell you a little bit about AMCHIP's role in the Safer Childbirth Cities. So in 2018, the 10 cities funded are listed here. There's a bunch of them. You can learn more about their projects at the website. And then in 2021, 10 new cities were funded. And this is our network map to show the different cities that we're working in. So I know you are wondering I guess not out of order, sorry. Let me just move forward. I know you're wondering what AMCHIP's role is. So AMCHIP, as you may or may not know, is a national resource, a partner and advocate for state public health leaders and others working to improve the health of women, mothers, fathers, parents, children, youth, and all families, including individuals with special healthcare needs and LGBTQ+ people. AMCHIP builds successful programs to serve its members, which are Title V members, by disseminating best practices and advocating on their behalf in Washington, D.C., as well as providing technical assistance. So with the Safer Childbirth Cities, we really provide kind of a technical assistance aspect. We support a community of practice of the grantees and hold space in collaboration with National Healthy Start Association and the National Birth Equity Collaborative, so NMHIS. You might be asking, what is a community of practice? A community of practice is a learning collaborative where participants share a common problem or mission. I think in this case, it's definitely that it's a passion that they share. We're all trying to reduce the outcomes that we're seeing, the negative outcomes that we're seeing right now. When well facilitated and participant driven, COPs are an effective space for problem solving, sharing, seeking new experiences, adapting existing assets, identifying synergies, testing ideas, and innovating new strategies. Here you can see that this is a tree that's growing. I would say that we're starting to enter the growth phase. Although we don't invite new members to the COP because our COP is a closed invite only community of practice for the grantees, I think that we're really starting to grow our networks within one another, because oftentimes these community-based organizations are ones that would not usually talk to one another or not usually know about each other, although they're doing very similar work. I'm going to run us backwards. Sorry about that. I want to talk a little bit about A few of our grantees, you can learn more about it on the website, of course, but I want to highlight Restoring Our Own Through Transformation, which is ROOT, out in Columbus, Ohio. Their mission is to comprehensively restore the well-being of their community through collaboration, resource allocation, research, re-empowerment in order to meet the needs of Black parents and families. They provide direct services, so like doula care and just prenatal care. Um, Public health policy advocacy, education in alliance with their local and national stakeholders. So this is kind of an example of like who is in our cohort 1. And then in cohort 2, there is the Maternal Health Equity Collaborative. They're out in Texas, and they are 4 community-based doula organizations with 2 parent advocacy groups that came together because they're trying to build out an infrastructure to provide childcare to their clients and their doulas. So oftentimes, when people give birth, this is not their first child. They might need additional help getting to appointments because they have children to take care of. So the idea is that by providing childcare and meeting this need, they would be able to get more people to those vital appointments and be able to have the time and space to really relax and have their mind clear to ask the questions that they need to ask. They are working on creating political will together and making this happen through collaboration, publishing reports, and connecting with, and they are themselves experts in reducing racial disparities. So that's the end of my part of the presentation. You can reach out to me if you have any other questions. I should have mentioned this at the top of the session, but you can put any questions in the Q&A and we'll get to it at the end. I am really excited to pass the baton to one of our grantees who are going to talk today about their program out in Chicago. So I will let Jenna and Kirby take it away from here.
Thank you so much. My name is Jenna Wallander-Gemco. I'm joined with my colleague Kirby Range. We are representing a lot of folks across our 2 organizations at Alliance Chicago and EverThrive Illinois to talk about our work that was funded through the Safer Childbirth Cities initiative called the Chicago Collaborative for Maternal Health. Next slide, please. There it goes. Okay. So of course, the issues of maternal mortality and morbidity are not new to a lot of the folks on this call. And really this Chicago Collaborative for Maternal Health was an effort across both Alliance Chicago and EverThrive Illinois in reaction to what we were seeing on the ground in Chicago and Illinois that was aligning with national data. The Illinois Department of Public Health found that non-Black birthing people were 6 times, non-Hispanic Black, birthing people were 6 times as likely to die as non-Hispanic white birthing people of a pregnancy-related condition, and 72% of those pregnancy-related deaths were deemed preventable. And the Chicago Department of Public Health found that the rate was 2.5 times higher in the city of Chicago for non-Hispanic Black birthing people than their white counterparts. Also impacted were those with high economic hardship and those with chronic conditions. And this, of course, has been exacerbated and highlighted by the COVID-19 pandemic, as we have all seen with our work on the ground. And so we were really excited to be funded by the Safer Childbirth Cities initiative in order to launch the Chicago Collaborative for Maternal Health as a partnership. We seek to combat the maternal mortality and morbidity crisis in Chicago by building awareness in communities and government, fostering collaboration among health and social service providers, and driving quality of care in ambulatory care settings. We have 3 major aims. The first one, which was led by myself and Dr. Lisa Masinter at Alliance Chicago, was to develop a quality improvement collaborative for ambulatory care providers focused on best practices in maternal health for systems and culture change. EverThrive led aims 2 and 3. Aim 2 was to implement a complementary community engagement effort that informs families and community and social service providers about maternal morbidity and mortality prevention, and then to determine and advocate for policy recommendations based on the learnings from Aims 1 and 2. Next slide, please. And so this is our organizational structure. As you can see, Alliance Chicago and EverThrive were co-leading this effort, but this effort was informed across all of our aims by a wide variety of local and state stakeholders through our steering committee. And most importantly, was informed by people with lived experience, which Kirby will speak more to in her portion of the presentation. Next slide, please. And so before I dive a little bit more into Aim 1, I just wanted to highlight Alliance Chicago's mission. Alliance Chicago is a health center controlled network of federally qualified health centers, both located within Chicago and around the country. Our mission is to improve personal, community, and public health through innovative collaboration, and we're focused across 3 core areas, which are healthcare collaboration, health information technology, and health research and education, where this effort lies. Next slide, please. As we engaged stakeholders for our work in Aim 1 for this quality improvement initiative, we developed this roadmap with the assistance of the Illinois Perinatal Quality Collaborative, and we've really been grateful to lean on their expertise. Each of kind of the steps on this slide have really been important to informing the work, but most important to us was that the topic that we chose was going to be informed, developed, and implemented by our partners fully. And they were also we did this through a community needs assessment and basically a survey where we invited all of our stakeholders to provide ideas for a quality improvement initiative topic. And we'll get into kind of what they chose, but most overwhelmingly, the interest was in the postpartum period. So then we also spent some time reviewing literature and informing the topic further. We worked with the health centers that we were working with to develop an intervention to test and establish evaluation measures for testing. We implemented in 2021, and now we are really excited to share the results of that work. Next slide, please. Oh, I think back one maybe, yep. So starting out in late 2019 and early 2020, we really hit the ground running in terms of engagement of health centers across the city of Chicago. We reached out to 18 across the city. 13 ended up participating in our quality improvement subcommittees, so that larger group of stakeholders that were informing our topic. And then 6 health centers ended up fully implementing our quality improvement initiative, with 5 still implementing the workflows that they developed today. Again, like I said, overwhelmingly, the postpartum period was prioritized through this engagement effort. The highest priority of the health centers being a linkage to primary care providers following a medically complex pregnancy, which is recommended by the American College of Obstetricians and Gynecologists. ACOG recommends that postpartum care providers should include the transition to well person care as part of the postpartum care plan, and additional referrals should be made as appropriate. And I should note that we conducted this survey pre-pandemic. I want to say it was like March 1 of 2020, before things really started to shut down. We did survey partners again as the pandemic progressed, and this was still of interest of them to prioritize. Next slide, please. So as I said, our global aim was to improve the number of patients with pregnancies complicated by medical conditions who were linked to a primary care provider or their primary medical home within 6 months of delivery. And so then we started to think again in collaboration with our health centers about different ways to measure this approach and evaluate it. And so from a structural perspective, we wanted to know if all the steps were in place to do this work. So establishing criteria for identifying high risk or medically complex prenatal patients, developing a registry, some sort of process of keeping track of these patients, both adding them to the list and then discharging them once they had been connected or outreached to. And then for the process piece, ensuring that staff who needed to know about this effort were trained, and how many locations of care at each health center this was being implemented. And then our primary outcome, of course, was how many patients were getting that primary care visit after routine postpartum care. We also did take a look at postpartum visits just to ensure that patients were being followed through the duration of their postpartum care. Next slide, please. So I'll move into sharing some results, but first I want to highlight the high-risk criteria that each health center used for their patient population. We tried to make this effort as flexible as possible, right down to this criteria selection. So every health center was able to select criteria based on what they were seeing on the ground and responsive to their patient population. All of them ended up looking at patients with diabetes and gestational diabetes. The majority also looked at hypertension and preeclampsia. We also had a few health centers that were looking at building this process into a multi-risk stratification process they were already using in the prenatal period. And then we also had some health centers looking at depression. Next slide, please. So as you can see at the baseline, in terms of a process to coordinate care back to the medical home, at baseline, some health centers were already starting to develop such a process, but nobody had a process implemented. And by the end of implementation, all 6 were fully implementing this process to coordinate care back to a primary care visit or medical home, which we're really excited about. And again, as I said, 5 out of those 6 are still implementing a process in some way that was developed from this work. Next slide. In terms of our process measures, by the end of the initiative, 54 staff were trained across all 6 health centers, and part of that training was done in partnership with EverThrive, which Kirby will speak to. And this initiative was implemented at 19 locations of care across those 6 health centers. And finally, our biggest result or most exciting result was this looking at this proportion of high-risk patients that were accessing primary care. So we did look at the baseline period of the calendar year 2020, and we found that 25% of high-risk patients, as defined, as I said earlier, with those varying criteria, 25% of them were getting connected back to primary care after delivery and routine postpartum care. And through this effort, and it was no small effort undertaken by all these health centers, we are now at 72% of the patients, or by the end of implementation, we found that 72% of the high-risk patients had a primary care visit at the end of this implementation period. So almost triple our baseline, and a pretty significant increase on behalf of all the partners. Next slide. And as this was such a huge result, an exciting result, it was not without its challenges, particularly COVID, as the big elephant that continues to be in the room. So we had initially decided to hopefully implement 2 to 3 quality improvement initiatives across the course of this work. And based on the healthcare community response and capacity shifting to addressing the needs of health centers and their patients during the COVID pandemic, we had a lot of implementation delays. But I will say that this delay actually resulted in some more intentional planning, and I think we may not have gotten the results we had if we had not been able to keep in constant contact through asynchronous, email and then synchronous Zooms and all of the ways we tried to keep in touch and really tried to keep this as low lift as possible, given that the health centers had so much else going on. Next slide. We also partnered with the University of Illinois at Chicago to do a qualitative study to look at the experience of participating in our collaborative. So there were 11 folks across the 6 health centers that were participating who were interviewed, and those key informant interviews have informed an analysis that we're still working through. But we have some preliminary results. We know, or from this work, that some major facilitators were the support and communication and having a flexible focus. I want to read this quote. Sometimes when you do these sorts of things, they want things by a very specific time, very specific criteria, and they were really open to us making it work within our clinic structure, which I think is both relieving, but also a smarter way of actually getting it done. And then some barriers, resources, training, communication, and data were also highlighted. In this quote, it's still kind of challenging to work when we're understaffed and know that you're putting something on someone's plate when their plate is already full. Next slide. We also did a secondary data analysis looking at postpartum care across the Alliance Chicago network to confirm if what we were seeing in the pilot phase, but in the baseline data was being reflected across our national network of data. So we wanted to see if how much the COVID-19 pandemic was impacting those results. And so we were looking for patients with a documented pregnancy outcome date in 2018 to see if they were getting a primary care visit within 6 months postpartum. Our main predictors were high risk status, insurance loss after 12 weeks postpartum, and engagement in care, which was defined by a postpartum visit, a first trimester prenatal visit, or any visit within 12 months prior to establishing prenatal care. We found in the larger cohort that over 85% had a documented postpartum visit versus only 17% having a primary care visit. We found that risk status, insurance loss, and engagement in care were independent predictors of the primary care visit. And then in the high risk cohort, again, we found only 25% with a primary care visit. So this, the bottom line is that the majority do not make that transition, even among high risk patients and even among those with insurance. And these findings have been accepted for publication by the American Journal of Preventive Medicine, which we're very excited about. Next slide. So just to wrap up AIM 1, like I said, I think our biggest takeaway from this work was that this was a health center and community-driven and informed approach from start to finish. The topic, the evaluation approach, the measures, and the implementation were selected and designed with the QI subcommittee. And the baseline data that we found both within the pilot setting and in our secondary analysis confirmed that the gaps that were identified just anecdotally by our health centers through that initial survey. And the fact, again, that the health centers were designing their QI workflows based on existing processes really, we think, led to that continued engagement and sustainability. As I said, 5 out of the 6 are still continuing those workflows, and the overall QI subcommittee remains engaged and has continued to partner with us on various pilots and proposals that have stemmed from this work. And I will turn it over to Kirby.
All right, thank you so much, Jenna. Hello, everyone. My name is Kirby Range. I'm the Associate Director of Birth Equity at EverThrive, Illinois. And I had the privilege of being able to be a part of AIMS 2 and 3, along with our wonderful community engagement team at EverThrive for the Chicago Collaborative for Maternal Health. So I just wanted to start off first with just giving you all an overview about EverThrive, Illinois. So EverThrive is an organization that seeks to achieve reproductive justice in the healthcare ecosystem. And our vision is to have a just and affirming healthcare ecosystem where individuals, families, and communities can truly thrive. We are committed to our values, which are reproductive justice, anti-racism, centering the most impacted, and bold action and transformation. Next slide, please. All right, and as I mentioned, AIMS 2 are focusing around community engagement. And so our goal is to really to engage community members as well as social service providers providing these very vital services within the community. And ultimately, throughout our whole process, our goal in all of this was to develop a very important and well-needed community responsive health education campaign out of everything that we were seeking to learn from the community members and the social service providers, in addition to us providing this rich education. So to start off this process, we needed to do a community needs assessment. We wanted to determine what are the community areas that we really need to focus our efforts in. And so we completed a needs assessment and we identified 6 community areas, 3 on the south side of Chicago and 3 on the west side of Chicago. Those included East and West Garfield Park, Austin, Inglewood, Greater Grand Crossing, and Chatham. And so those were our target areas, and we determined those to be the ones we picked because they had the highest maternal mortality rates, okay? So after we did our assessment, that led us into actually engaging with the community members. And so in year 2, we started to do community outreach, canvassing, providing surveys and focus groups for community members, so we could understand about what did folks really understand about maternal health and accessing services and postpartum care, excuse me. And at the same time, we were also seeking to engage the social service providers in those same community areas, really wanting to provide them a foundation on what is happening around maternal health in Chicago, in this area that they're providing these services. Do they understand about maternal mortality and the rates? And we also wanted to find out from them if they had any specific barriers to their families and to their participants, and what are they hearing from their participants regarding what they understand about maternal health as well. And again, all this information was going to be used for us to use to create this really important health education campaign. So again, this education campaign that we were really looking to do would not be able to be done unless we had community voice, which you'll hear me say frequently, because we are strongly believing in that, and really to have any type of transforming change within our systems, we have to have people with lived experience be a part of this whole process and to be able to let us know truly what is happening, so we have the accurate picture of where we need to go. Next slide, please. And so obviously, as Jenna had mentioned also, COVID-19 impacted so many people, so many organizations, and how we implemented our work. And we definitely saw that with our dissemination of AIM-2 priorities. Through it all, we're truly fortunate that we were still able to capture the information we needed and to engage people, even if it was in a virtual way. But we did want to highlight how COVID-19 impacted us. So some of the ways that we had to restructure AIM-2 activities included that we had to switch from doing in-person baby showers to doing something a little bit differently, which I'll explain. So originally we wanted to provide we wanted to join other community members in their baby showers, provide a baby item gift, and in turn provide some maternal health education for the mother to be in her attendees for her baby shower. And then also we would get to have that rich conversation about maternal health and understand more about what was happening in the community. Since we weren't able to do that, we did something where we had shop talks. And so in this case, we actually had the ability to actually do a virtual kind of like open roundtable discussion with several people who were coming for to get their hair done. And so we were able to engage with these different salon clients to be able to talk with them about their experiences, whether they were pregnant or parenting, or whether they had family members or friends who were pregnant and parenting. And we use this concept because we know that the salon or a barber shop or a nail salon are really places that people ultimately feel comfortable. They tend to talk to people in there and share their experiences and what's happening. And so we wanted to be a comfortable environment where people could share that. We also continued to do our focus groups, but we had to do those virtually instead of doing those in person. And instead of launching our education campaign in the 3rd year, we decided to push that back a little bit further so that we could actually do our health education campaign in person and engage with folks in the community area. We still also collected our surveys and spoke with community members, but we did this in a more safer way with using PPE equipment, ensuring that we had things to sanitize our tablets when we were doing the surveys. And instead of doing our maternal health trainings to social service providers in person, we shifted those into a virtual format and really tried to make sure that it was still a very engaging environment with having different ways that the attendees could engage with each other, whether it was small group discussions, large groups, you know, having different activities to work on. Next slide, please. All right, so we had a lot of success with providing outreach into the community areas. And so we were at health fairs, community events, back to school events. We reached out to local businesses. And so through all of our efforts engaging with the community, we were able to complete 330 surveys and 4 focus groups in our target areas with pregnant and postpartum people. So a huge shout out to our community engagement team for really being able to pull this off during the pandemic. Next slide, please. And so as I mentioned, we had 4 focus groups. And so we had some specific questions that we laid out that we asked our focus group participants to really understand about the barriers to care, maternal health terminology, things of that nature. And so you can see for yourself here on the screen the questions that we had. Some of them included, what are some of the things you would like to see in the community to keep people healthy? How well do you feel people in your community are supported during pregnancy? Have you ever heard of the term maternal mortality, maternal morbidity? Next slide. All right, and so ultimately, our objective was really around obtaining key information. And there were 3 questions in particular that we were really trying to get the most information from. And those were around the type of support people were receiving, the type of access to healthcare that they had, and also their perceptions of maternal mortality and maternal morbidity. So the questions here are, what type of support in the antenatal and postnatal period do women have access to? How do people who are pregnant access healthcare and health information? And what are people's perceptions of maternal mortality and morbidity? Next slide. And so to do this and to really understand about all the results that we obtained in the focus groups, we did a rapid qualitative analysis as compared to just doing qualitative research, which can take a really long time. And so with our rapid qualitative analysis, we were able to really, again, identify those key themes. And so we were really excited to go through this process as a team with doing the analysis. It was a first for us and really doing this qualitative methodology. And we were led by 2 wonderful doctors in this whole process. I'd like to give a huge shout out to our community engagement team, who was phenomenal throughout this whole process and with the analysis. So thank you to April Thompson, to Leva Johnson, Andy Baker, and especially the 2 doctors, Dr. Madeline Perry and Dr. Marquita Lewis-Thames, who were both with Northwestern. All right, and so next slide will show, go into more about our focus group themes and our survey findings. And so what we found are these 5 key themes here. The first one was that there is a need for support outside of medical care. And so we heard a lot about just the types of support that people needed, and definitely, which is probably no surprise, mental health was very high with our focus group participants. And so the next one was sources of health information are varied and not singular. And so what we're meaning by that is that there's a lot of different places that people are getting information. They refer to their healthcare providers as for information, social service partners, family and friends for information. So it wasn't just one particular place that folks identified where the information, but also multiple places. There's also a need for strengthened connection with medical providers. And so again, probably no surprise for all of us in the maternal health space, but there's a disconnect that participants or people are just having with their care providers. They're feeling that they're not being listened to, that they're not being treated with respect, or they're feeling that they're true individuals when it comes to their healthcare decisions and diagnoses and things of that nature. Also, respondents did say that they did not always trust their doctors and the advice that was given to them. The last two, familiarity with the lived experience of the postpartum period and maternal morbidity and mortality, but having the lack of medical information. So folks were able to share about their experiences with, having a baby, had babies, whether it's family or friends, that postpartum period, but they didn't really have the terminology to really share truly the information about what was happening to them. They didn't have like the medical language per se to really understand about like postpartum care. We also heard terms such as setback used a lot. And that was what participants were sharing about when they did have challenges in the postpartum period. And so we thought that was really interesting and took that into consideration when we were bridging how there is a gap in how providers and community members are understanding of different pieces of information as it relates to maternal health. And then on the right-hand side, you'll see a couple pieces of data over here. We had 66% of people reported that they had not heard about maternal mortality before, and 70% reported maternal mortality. And these next two slides that you'll see share some of the exemplary quotes that we felt really kind of provide a good essence of what we heard frequently from our focus group participants. I'll just read maybe about one or two from each of the slides here. So this person said, one of the main problems within our community is we don't necessarily have a strong support system while we're pregnant. We really don't know who to talk to or who we could depend on, because really, most of the time, we really only have ourselves. Okay. This person said, I definitely don't show trust the doctor, but my mom and all the women that had multiple kids and my family, I do trust. Next slide. On this one right here, this person said, but I think that our healthcare industry isn't designed to care about people. And I think when it comes to Black mothers, that's where the least care is given. So we heard these types of themes and responses frequently out of all four of our focus groups. Next slide. And so this brings us into the other component of our community focused work for CCMH, and that was to engage and activate social service providers. We know there are so many rich services that programs provide to pregnant and parenting people, whether it's family case management, doula services, home visiting services, mental health services. And so again, we wanted to find out from social service providers, what all do they know about maternal health and what's happening in Chicago and how they can best support their participants and families that they're working with. So far we have had 3 cohorts of organizations to participate. There's been a wide range of attendees, including family support workers, case managers, doulas, a men's health coordinator, lactation consultants, nurse interns. And so we've had a really wide group of people. 91 social service providers, 5 more additional organizations this month. Next slide, please. And so this shows you the overall goals of our social service provider training. We were hoping that through this training that organizations and the attendees could build awareness of maternal mortality and morbidity and the associated disparities. We wanted to activate social service providers and community. And then also we wanted to learn. We wanted to learn from social service providers about how to improve the system for women, for pregnant and parenting people. And ultimately, the curriculum was designed in a way that we were hoping that organizations could take this information that they learned, share it with additional staff, colleagues, new incoming staff, and be able to cater it in a way that they can continue to think about how they're providing their services for families and how they always want to keep how they're addressing maternal health in mind. And so we did complete some surveys with our social service providers to really understand how much knowledge they had obtained from completing this training. We had several participants attend. We did lose a little bit of our data, but from 31 people that were surveyed, we learned that had an increase in knowledge about postpartum birth warning signs. They also had an increased knowledge in how to discuss pregnancy and postpartum with the families that they were serving. Next slide. And these are just a few quotes just to share with you some of the reactions that social service providers had after they completed the training. And it just was very enlightening just to see the takeaways that folks had. I'll read a couple of these. One person said, "It was enlightening to have a deeper understanding of the stressors to the communities we work in. We were not surprised by this, but it also felt as if we had to search deep to figure out what were some of the strengths in the communities, which were few." And this person is referring to an activity that they did, a community mapping activity, where they had to think about what were the stressors in the communities that they were serving and what were things that were sufficient enough or working out. And so they found that they had, majority of the organizations had more stressors that were impacting families. And so we talked greatly about social determinants of health. Another person said that it's crazy that this mistreatment of Black women is still going on. And I think that it's so important to have community-based programs like ours available so that we can get out this information to young women. And this was an organization, a person that was supporting teen mothers. Next slide. And here you'll see what we learned across all of our engagement with our FQHC patients, with our social service providers, with our community members. And so in reference to FQHC patients, we learned that many of them did not understand what a primary care visit was or what to even expect during a primary care visit. For social service providers, we learned that they felt that they need additional information about postpartum training. They felt a lot of the curriculum that they have and they use with families is really focused on the prenatal period, but there's less information and tools to support them in understanding about postpartum care and how to support their families through that. They also felt that they wanted more resources on how to support people who are the supportive partners for people who are pregnant and parenting. So partners and grandparents, things like that. And they would also like to understand more about the different services that are offered through managed care organizations so they can share those resources with their participants. For committee members, we learned so many different things, but overall, we did learn that they need more support with outside medical care. They also need different sources of health information coming from multiple places. And that also there's this difference in language and with the associated gaps in understanding. Again, maternal mortality, postpartum, things like that were all just terms that were all not used too often. And so we can understand how there's a barrier when there's providers providing language or information to families, and it may not be in a way that they understand the best. Next slide. And so that finally brings us to the Gathering campaign, which we are extremely excited about. The Gathering was released in June of this year. And so again, the goal is to really reach people outside of the exam rooms and in the neighborhood. We really want to have these conversations with people about getting connected to primary care. We stress that so much in our conversations about the need to really advocate for your postpartum health, advocate for having a primary care visit, and making sure that you have things that you need in place to understand about your health needs after having a baby. And so this education in this campaign is really kept simple so folks can understand it in a way. And it was really stemmed by just our conversations again with community members and really just the overall design and feel of the actual toolkits, the different campaign information that we have. And we have pictures of people that reflect the communities that we focused on. We're so excited about this. And again, the campaign is really just addressing loud and clear what we heard through all of our focus groups and conversations. We wanted really community members to understand that they are disproportionately impacted and that we want to do our best to really leverage the needs of communities and help them to understand just their role and just advocating for what they need and just also having the tools that they need to understand what is happening. You know, we want to bring those resources to people and to organizations that are serving people in the community. And so we also partnered with the Chicago Department of Public Health to help promote other vital maternal health and postpartum projects that are happening, like Family Connect Chicago. And also we have the One Shy Family website listed in this campaign as well, because we want to have multiple modes of information and resources for people. So again, we've had a lot of success so far with the campaign in just the couple of months that we've launched it. We have trained 6 peer outreach workers to have one-on-one conversations with community members at like health fairs, street outreach, things of that nature. We have also launched our digital media campaign, which has already hit our goal to reach 30,000 people. We have already reached 34,288 people who are viewed our campaign online. We had a successful engagement with our social media ads as well, with an above average click rate of 1.12%, the number of people who engaged with the ads linking to our campaign website. So we're excited about all the results that have happened so far. And we love for you all to help us in amplifying this campaign. If you can go to the next slide, please. And especially if you are here in Chicago, you'll see there is a complete set of campaign guidelines that summarizes how to use all the digital assets, the campaign timelines, and sample messaging that you can use. This digital campaign includes a wealth of resources, our landing page, fact sheets about what to know during pregnancy, fact sheets about after you give birth, fact sheets for family and friends to utilize, a glossary of terms for doctors and clinics. Again, we talked about some of the terms that community members would use and how they're different from what providers may use, such as that term setback. And then also we have several social media graphics, again, that reflect the community, the people that we focused on. And then the gathering video really just kind of summarizes everything that we're doing with this campaign. So if you go to the next slide. And so you can really help us amplify the campaign, again, by using the campaign guidelines. You can see our, if you need more support with this, our wonderful community engagement director, Tamala Milan Alexander, her contact information is on here. She can support you with further information and questions. And we encourage the materials to be handed out at the targeted locations that we prioritize through this, which again include East and West Garfield Park, Austin, Greater Grand Crossing, Chatham, and Inglewood. Okay, slide. And that brings us to our last aim, which is focused around policy. And so we are in the process of creating a community-informed policy agenda. And our agenda and brief are really guided through having this collective voice from all who are part of the Chicago Collaborative for Maternal Health. We know that we need this collective voice to really have an informed agenda. So this includes community members, clinicians, our social service providers, and our wonderful steering committee to really guide this. And so we are seeking to develop this brief to really address the structural barriers to healthy pregnant and postpartum people and their families. So we're working really hard to put this together now. If you go to the next slide. And so we're seeking to have this implemented in August now, so hopefully this month. And the goal and objective of this policy brief will be to educate policymakers and others interested in influencing policy about the issues faced by clinicians, social service providers, and community members contributing to the maternal mortality crisis on the south and west sides of Chicago. So stay tuned with that. We will have a couple of webinars to accompany that policy brief as well. Next slide. And these are all of the wonderful people who are part of the Chicago Collaborative for Maternal Health. Again, we understand that it is a collective process to really tackle this maternal mortality crisis, and we could not have done it alone. So a huge congrats and thank you to Alliance Chicago, EverThrive Illinois, Northwestern University, the University of Illinois at Chicago project team, and also thank you to the Illinois Perinatal Quality Collaborative and the people with lived experience who served as key advisors for this work. Thank you all so much.